Welcome to the Liver Lounge, your go-to podcast for the latest updates in hepatology, featuring discussions with the world's leading experts.
Thank you so much for joining us today. So today we have Professor Jeffrey. So he's a very famous researcher in the field of MASLD and has done a lot of the public agendas effort pushing for future clarification into the research agenda priorities into MASLD. So Professor Jeffrey, can you just bring us through how was the path to MASLD originally found?
The path to MASLD, you mean the name change?
Yeah, the name change.
Well, as you know, non-alcoholic fatty liver disease was really defined by Ludwig at the Mayo Clinic back in 1980, when they had after a series of case reports of people who had everything that looked like alcohol, or they called it alcoholic-related liver disease, but they reported not drinking alcohol. And that's when they were able to define this non-alcoholic fatty liver disease. Since then, although the name stuck, there has been lingering concern about defining a disease by what it is not rather than what it is. And later, just concerns about having the word alcohol in the name, which is difficult or contentious in some settings where there's not much alcohol use, if any, as well as having the name or the word fatty in the name. Not by everyone, not even necessarily by large groups, but it was felt by some to be stigmatizing, and that really pushed for this name change.
Right. And, moving on from there, I think that the consensus was later published and with many liver societies on validating the use of MASLD. So could you share with us, like, how has this combined effort changed the global landscape in terms of how do we approach MASLD? How do we combat MASLD in the future?
It was a very long and complicated process, and ultimately resulted in the use of the Delphi method, which I've been using in other disease areas, HIV, COVID-19. So together with Professor Diana Romero at the City University of New York, the Graduate School of Public Health and Health Policy, we led the methodology, and EASL-D and EASL had co-chairs, engaged ALE, the Latin American Society, and APASL, the Asian Pacific Association for the Study of the Liver, to nominate representatives to be a part of the process, so that it really and truly would be a global process with experts in the field, and that includes many clinicians and researchers, but also patient group representatives themselves. So the official name change was launched at the EASL Congress in June 2023. And what it does is it really marks a change in how we think about what we now call steatotic liver disease or fatty liver disease. We may still describe it to patients and others as fatty liver disease, but it means you can go home with a diagnosis with a disease name that doesn't say alcohol, it doesn't have alcohol in it, and doesn't have the word fat in it. Among us, sure, we can still talk about excess fat in the liver, or even call it fatty liver disease if that's easier with some colleagues. So the big change is calling it metabolic dysfunction associated steatotic liver disease. So that brings into play the important role of diabetes, obesity, other conditions that we've always known, but it's been hard to engage colleagues. Why should they be interested? Now we have a name that says, of course you should be interested. It's metabolic dysfunction associated. So I think that's going to be a real sea change in engaging obesity management specialists, engaging endocrinologists. And I think to some extent, primary care will start to get more on board, because right now, even with this incredible prevalence of MASLD among people with type 2 diabetes, the last studies are showing almost 63%, you don't have regular testing of everyone for MASLD. And one of the reasons we're told is that, well, there's not much they can do. There's no specific drug. They're already dealing with diabetes. They might already be dealing with dyslipidemia, obesity, and so on. But there's actually a lot you can do. Plus, we know that when patients hear that they have another condition, it can also motivate adherence to the drugs and medicines that they're already on, or even the lifestyle interventions that are recommended.
Right, right. Actually, the study of prevalence of NAFLD in gut diabetes was actually something that they wrote it. That's published in Gut. Yeah, we found like 66% of people with type 2 diabetes have NAFLD.
Yeah, there's that study that has 66%. There's Zabaryonasi's that has 62.25%. But the point is that,
It's
almost 2 out of 3 people, however you slice and dice the cake, with diabetes type 2 has MASLD. So they need to know they have it, regardless of whether there's a specific, MASLD or MASH drug approved.
right. And I think before the introduction of MASLD, you did a study showing the research priorities. I think something about public agenda and how unprepared we are for NAFLD. Do you think with the introduction of MASLD, would that change government policies and how we approach MASLD?
Well, we have a unique opportunity now to really raise awareness. As we're raising awareness about the new name, we need to raise awareness about this condition, the high prevalence, the interaction with diabetes, that this is the hepatic manifestation of metabolic syndrome. So, we've been pushing really hard to develop a public health and policy agenda for NAFLD-NASH, now MASLD-MASH, because WHO is not addressing it at all. So it's not on the agenda of the World Health Organization. It's not on the agenda of any other UN agencies. And you can compare that to HIV or viral hepatitis or many other conditions, particularly infectious diseases that are addressed not just by WHO, but by UNICEF, UNFPA, of course, UNAIDS, UNDP, and others. So in the absence of any major global organization addressing this, we brought together the field, almost 400 people from almost 100 countries and territories to really declare this a public health threat. That was published a few years ago as a consensus statement in Nature Reviews GastroHep, and then following on with the research and action agenda that you mentioned, a set of priority actions and research priorities that we need, that the world needs to implement. Doesn't mean you can't do anything else, but all other conditions have, action plans, they have frameworks, they have strategies. The field needs something to guide the field, as well as something we can measure progress against. So something else we did was place steatotic liver disease or MASLD into the Sustainable Development Goals and show how countries have done if you took the most relevant Sustainable Development Goals. The SDGs is a set of 17 goals that all UN countries, all UN member states have agreed on. So really, they're doing this already, but what does it really mean for MASLD? So there's items and indicators like urban green spaces, access to food, poverty, education, all incredibly relevant for liver diseases like MASLD. So we can say, look, you're already addressing MASLD, but you really need to call it out. You need to mention it specifically in your health strategies and action plans. So that means to start with, when you have a diabetes strategy, when you have a cardiovascular disease strategy, when you have a physical activity strategy, at least mention that one of the other benefits in a physical activity strategy is going to be improving your liver health, why that's important, emphasizing the bi-directional relationship with diabetes and other conditions.
Right, right. And since you mentioned this research agendas, I mean, transition to that, I was just wondering if you can bring us through what are the future research agendas for fatty liver disease or MASLD?
Well, I mean, no surprise, the domains really follow the public health consensus domains. So of course, no surprise that treatment and care is a top research priority. But so is improving diagnostics. I mean, there were recent FDA hearings, and they're still not allowing NITs, non-invasive tests, to replace the liver biopsy. But we need to look at, well, okay, maybe one or two of them together is not good enough. But what happens when you have 3 NITs? Because the biopsy is far from perfect anyway. But how will that measure against a biopsy? And can we say if you used a FIB4 and an ELF and a fibroscan, that actually that's good enough as the proxy indicators for having MASH and for demonstrating fibrosis. So NITs, treatment and care, but also research priorities around growing the community of practice. So who are the stakeholders and how do they engage and how do we raise awareness among them? How do we study leadership and the engagement from policy and decision makers and authorities? Really things we've done in other fields. So there's nothing super new here, unique. The details are unique, but the areas mirror what's been done, particularly with HIV and viral hepatitis that I'm most familiar with, but which you also find in diabetes, cardiovascular disease, other major non-communicable diseases, of course, all of the cancers. And then another important research area is models of care. What works best? We're not going to resolve this issue, this major issue, just from hepatology and other liver specialists. So how do we engage, and in what ways do we build teams, provide multidisciplinary care, address this in the community? One of the biggest changes in HIV was, back in 2010, I think it was, the Ginger study published in the Lancet and led by Professor Jeffrey, when he showed non-inferiority of providing antiretroviral therapy in the community. WHO changed their guidelines, started treating people in the community, and treatment, scale up really took off. Mortality fell. The spread of HIV fell because people were, suppressing the virus. So we need these kinds of studies on models of care. What can we do in the community? How can we test for fibrosis in the community and then figure out, is it because you have viral hepatitis B or C? Is it because you have MASLD? Is it for another reason, or is it for a combination of those reasons?
Okay. So, I mean, it sounds like primary care is going to form a major part of MASLD care in the future. How do you think we should, outreach to primary care health providers? Because they already have a lot of things to think about, right? So, how do we make MASLD one of their priorities?
Primary care will absolutely play a major role. And if there's a GP listening thinking, oh, I just don't have any more minutes in the hour to address this, the good news is you're probably already addressing it. But and by pointing out that the care you're providing also prevents or even treats MASLD, because we know lifestyle interventions is a form of prevention, but also a form of treatment and care, then that helps adherence. We led a study, and others have been involved, showing that knowing the stage of fibrosis led patients to adhere better to lifestyle interventions. So primary care needs to say, hey, you're overweight, and right now they'll say, and that's a problem because of cardiovascular risk, it's a problem because of diabetes, and now you need to add in and say it's a problem because of liver disease, specifically MASLD, because if you get MASLD, it can also lead to or contribute to diabetes and cardiovascular disease. So it's one more kind of tool that the primary care physician can use when they're advocating for the changes in lifestyle that they're prescribing now to address conditions that they're diagnosing or caring for. And then when it gets serious, if it gets serious, they need to have better risk stratification. So we need automated FIB4 where that's possible. It's not the best diagnostic tool, but it's also not bad in some age groups. We need, some cases, there'll be a fibroscan, or you'll be able to get an ELF test, and then stratify, send those in need of specialized care to the specialists. there's enough people to go around. So save those in most need to go to the hepatologist, and everyone else stays at primary care and gets the same kind of care they would, because they probably, or now with the MASLD definition, they will have another condition. So you're going to be dealing with diabetes, you tell them about MASLD. You're going to be dealing with cardiovascular disease, dyslipidemia, something else, then tell them about the MASLD.
Right, so it kind of work in conjunction. I think in that way, it's much easier for primary care providers to give a reason for patients to go and follow up on this disease. I think, although I feel like the risk stratification at primary care is quite difficult, given the NITs that you have. We mentioned a lot about the FIT4, and FIT4 was invented in the era of hepatitis C. And there's many studies that have shown that FIT4 is not particularly good, at least in the community setting, because of the different test sensitivity and specificity that you have. I guess with the introduction of better NITs, ELF, FibroScan, although a little bit expensive, not very accessible in that sense, that perhaps would be able to allow better risk stratification at the primary care level. I guess in a way, MASLD management is very holistic. So we talk about primary care. How about governments and as well as public policies? Where do they come into this?
Well, first, let me just make a comment about the diagnostics. I mean, I predict the diagnostic tools are going to get much better, because we're also going to be using machine learning and artificial intelligence to really scan patient records and see where we think those in need of a test, or who they are, and get them that test. So we'll have these digital tools to both start to make predictions, to identify who's maybe more in need of a test than others. There'll be, in some countries, there's specific testing centers. In some cases, it's primary care. So you can go to Spain, your doctor says you need these tests, and then you go to some testing center near where you live. The doctor actually doesn't do it, and then they get the reimbursement through the testing center. So there's many different models, and that's why we need to look at the models of care. And if digital tools will help us identify who's most in need of getting a test for MASLD, and we can also use digital tools to take care of people. So there'll be adherence support through messaging. There's everything that's there for obesity and diabetes, better recipes, better ingredients, so you can substitute healthier foods for others if that's something you're interested in, reminder systems, and so on, a whole range of digital therapeutics. And that field is moving so fast that if I gave you a couple examples now, in 6 months, they may even be gone and there'll be new examples. So we have a lot to watch and a lot to do in the digital field that will make things easier. Now, in terms of the policies, I mean, as you know, we reviewed a few years ago, do countries have the right policies in place? And every country failed spectacularly. I mean, if they were at medical school, every single person failed. And, the countries that did best, like England and the UK, still failed. They just didn't fail as badly as everybody else. So I wouldn't exactly be proud of that. Things have changed in the last couple of years. There's a plan in the US. There's really a lot of attention in India. I was just there. It's very exciting what's going on there. The attention being given to steatotic liver disease at the highest levels, the plan they have, the treatment they're using. So, we'll repeat this study next year. We ran it in 102 countries. We'll expand that. We'll engage 400, 500, 600 people in the field to really make sure we have the latest data, fact check it. And hopefully we'll see that some countries don't fail. And hopefully we'll see that most countries have improved. We did this on a score of 0 to 100, and a third of the countries scored 0. So, I'm a very ambitious person, but I'm hoping, maybe no country scores 0. And if you had a 42, maybe now it's a 61 and you're passing. And now people say, well, having policies doesn't mean they're implemented. And that's true. So, in other fields where we did this in viral hepatitis already 10 years ago, the next step was, well, you need to implement those policies. And that's where, the role of community-based organizations, non-governmental organizations, even clinical societies as watchdogs can say, you have this policy, you're not implementing it well, and this is what you should do to implement it better. And we need to distinguish between policies and clinical practice guidelines. So there's great CPGs out there. There's the new AASLD guidance, and all the major societies have it. And some countries have their own, some just use the existing guidance. In Europe, a lot of smaller countries might say, we're just going to use, the EASL, SLD guidelines. So I'm really commenting here about the policies that need to be in place. And then I would add to that, where there are strategies, as I mentioned earlier, that are, of conditions that are closely related, common comorbid conditions with MASLD, they really need to mention MASLD. I don't think you can say I have a good diabetes action plan if you haven't mentioned liver disease once. I mean, as I often say, when you search these strategies, at least the ones in English, and you search for the word liver, the only time it ever comes up is a part of the word deliver, to deliver on cancer care, to deliver on diabetes care, but we need to deliver on the liver. And that starts by mentioning it and then actually, devoting some proper attention. I think that will be an important component of really people-centered or patient-centered approaches that start to look at the individual from a more holistic and comprehensive perspective, instead of saying, well, I'm an endocrinologist, I deal with diabetes, I'm not even going to test for MASLD. I think that's a huge mistake, and it repeats what happened in the early days of HIV, when everyone with tuberculosis wasn't being tested for HIV, really until WHO came out with its recommendation. And big surprise, so many of those people, particularly in Russian or former Soviet prisons, but also across sub-Saharan Africa, those with TB also had HIV. It was pretty obvious. It was a very high percentage. We know that percentage now in diabetes. So my question is, why are we not testing everyone? And if there was an endocrinologist on the line, I think I even know some of the answers, but still I would argue, and there's a new piece coming out in Lancet GastroHep from a bunch of us calling for, sort of a liver check among all those with diabetes. They do need an NIT at least once.
Okay. Thank you so much for your time, Prof. I think it's very interesting, and thank you for all the innovative approaches that you've done for MASLD. I do hope that moving forward, we have better strategies to improve diagnostics and awareness of the disease, and for more people to be more concerned about MASLD, given the prevalence and the implications of MASLD.
Well, thank you for having me, and I hope everyone listening will really engage and remind their hospital administrators, their clinical colleagues, politicians, if they know any, and decision makers, that it's now MASLD. It's metabolic dysfunction associated steatotic liver disease, and that means we really need to improve our models of care. And in general, given the very high prevalence, over 1 in 3 adults who have MASLD, and then a smaller but very large proportion who have MASH, we really need to identify these people and provide them the treatment and care that they need and deserve.
Yeah. Okay. Thank you so much, Prof.
Great. Thank you.
We have come to the end of the episode. Thank you for joining us, and stay tuned for more captivating discussions.